I'm Ramaswamy Govindan, a medical oncologist at Washington University School of Medicine. We'll go ahead and introduce other panelists here. Dr. Lanuti.
Yes, hi, Michael Lanuti. I'm a thoracic surgeon at the Massachusetts General Hospital in Boston and the director of thoracic oncology for our division.
My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis.
I'm Sanjeev Bala. I'm the head of cardiothoracic imaging here at WashU in St. Louis.
I'm Dr. Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine.
We have a gentleman, 66-year-old, former smoker, with a newly diagnosed stage 3C adenosquamous superior sulcus tumor of the left upper lobe, with direct extension to the left fourth rib and hypermetabolic supraclav node. The PD-L1 was negative. We are going to be discussing the optimal treatment for this superior sulcus tumor and the question about whether the histology or the rib involvement would change the treatment approach. So this patient presented with chest pain, as you can imagine, fatigue and some shortness of breath, and has a fairly unremarkable medical history, benign prostate hypertrophy and hyperlipidemia, and has a 50-pack history of tobacco smoking, quit 14 years ago, with no family history of cancer. Let's review the films. Dr. Bala?
So on the non-contrast CT, we can see that there's a large left upper lobe mass, and it's involving the chest wall, particularly in the region of the left fourth rib.
And so, thank you. This patient underwent a bronchoscopy and had a biopsy of the left upper lobe mass, and FNA showed poorly differentiated invasive adenosquamous carcinoma, positive for TTF1 and CK7, NAPSIN P63, CK56. The lymph nodes were negative, 4L and 11R, and the tumor markers were negative for PD-L1. And this patient had a PET-CT, and that showed the same mass and as well as the supraclav node with an SUV of 5.3. Bone scan did not show any metastatic disease, and MRI of the brain also showed no evidence of metastatic disease. So this is an interesting problem we have not infrequently. So the question really is, how do you approach this disease? We'll start with Dr. Lanuti. Your thoughts, please.
Yeah, so this genre of tumors, the pan-coast or superior sulcus tumors, have specific challenges, and that is, can a complete resection be achieved? If it's really a true superior sulcus, we worry about reaching up into the brachial plexus or perhaps even vascular structures. And so we do rely on this notion of induction for these tumors. And similar to a pretty old trial that we still use is the SWOG 9416. That is, we like to induce with chemoradiotherapy followed by surgery. Why radiation? Well, our margins are sometimes not perfect. We need a little bit of an additional local boost. One thing that we all would agree that these patients, if they have N2 disease, they often are bad actors, and we don't necessarily often apply surgery to the N2 positive patients. So the emphasis would be truly very good, high quality invasive mediastinal staging. To that end, having a negative 11R and a negative 4L, to me, is just not enough. I would have wanted to more aggressive staging, level 7, something 2 or 4R on the right, to really complete the staging. And then this idea of rib invasion, that's not really something that is a deal breaker. We can remove bony structures all the time, all the way up to the first rib. And there are times when we can take the T1 nerve route without a lot of implications that are debilitating.
I have a question for you. So when would you insist on getting an MRI of the brachial plexus?
Yeah, great segue. I think that with tumors that are all the way up at the apex, I often do get the MR just to get the sense of proximity. And if there is a lot of arm deficit, that would often be your clinical correlation. But if there's not a lot of arm deficit, I still get the MR just to see proximity, to see where am I in regards to the cords, if you will. And then in terms of vascular structure, sometimes it helps me there as well. We can reconstruct artery, subclavian artery. Sometimes we actually tie off the axillary vein, but sometimes we reconstruct it. So the vascular invasion that used to be thought to be perhaps a hiccup is now better managed.
Since we're talking about all those difficult things, I may as well ask this question. How about the thoracic vertebral involvement, or if there is, let's say, destruction of the T1 or T2, but no nodal involvement, no brachial plexus involvement, would you proceed with operation at some point after chemoradiation? In other words, apart from the nodal involvement, when would you not operate? Brachial plexus involvement, I would think, and then vertebral body involvement.
Yeah, so that scenario of T4 vertebral involvement, that is not something that we'd shy away from. So that is, we would often consult with our spine surgeons, be it neurosurgery or orthopedic surgery, and we could do a 2-stage operation to support that vertebral body that needs a laminectomy or some kind of reconstruction. So if you told me, well, there were 6 vertebral bodies involved, I might shy away from that. But if there's 1 or 2, we would still want to be aggressive, as long as they were an ideal candidate, node negative, optimized, if you will.
Yeah. I would think a brachial plexus involvement would be a contraindication for surgery, I would think, right?
Yes, it is. If it just touches the very inferior margin of the brachial plexus, we sometimes can get away with some cytoreduction there, often relying on our radiation colleagues to help us. But if there's true invasion of the brachial plexus, that is the contraindication.
Yeah. Thank you. Dr. Robinson.
I think that's all very well stated. The 2 things that come to mind to me specifically for these patients, particularly with radiation, is that the morbidity of recurrence is extraordinary in this patient population. So, not that any lung cancer that recurs is always bad, but in particular for these superior sulcus tumors, it can lead to extraordinary pain and disability. And so, I think that having that very nuanced discussion about even pushing the limits on some surgeries that we might not consider for other situations is reasonable. And then, I wanted to also highlight as well, just that in this case, the patient did get a brain MRI, but, it's often the case that in node negative disease that people may not consider getting brain MRI. However, the incidence of brain mets in these patients is extraordinarily high.
Thank you. Dr. Levy, your thoughts?
Yeah, very difficult tumor to treat. I think in terms of chemotherapy selection, this is where we have most of the data with etoposide. This is the SWOG regimen. This is not for the faint of heart, however. This is cisplatin day 1 and 8, etoposide day 1 through 5, given every 28 days concurrently with radiation. So generally, if the Dr. Lanuti told me and the radiation oncologist this was surgically resectable, I would be offering concurrent chemotherapy with radiation. If a patient is less fit and can't tolerate the etoposide, we could certainly give weekly carbotaxol.
Interesting point. I mean, of course, we all fall back on the great SWOG study that really gave us a nice basis for designing these regimens. And etoposide with radiation used to be our standard treatment for all locally advanced non-small cell lung cancer. In fact, for the greater part of my career, I used to use that regimen until the Jeff Bradley RTOG study showed paclitaxel carboplatin in the modern day produced just as good results as historic results with platinum etoposide given in systemic doses. So I think it's a tougher regimen than paclitaxel carboplatin, but certainly something that I really think would be the appropriate. An interesting question, Dr. Levy, to you is that, let's say this patient goes to induction chemoradiation, has surgery, and then has no residual disease or has minimal residual disease. Would you consider giving this patient durvalumab?
Such a great question. I think this has come up several times before. And, the data that we have with durvalumab is for unresectable stage 3 lung cancer, a la the Pacific trial showing a very significant benefit in overall survival, I wouldn't. I'm sometimes borrow and say, look, this was unresectable data, and we have a resectable patient who still got concurrent chemoradiation. That said, we know that these patients are at high risk of relapse. And the question is, should we act now, borrow the data from the Pacific trial, which was not for resectable patients, it was for unresectable patients. I think this is a discussion with the patients. I have had this occur now twice. And in my practice over the past 6 months, where very savvy patients have come to me and said, I got concurrent chemoradiation and I know I got surgery, but I also want something on the back end. Even though I got surgery, I still think I should be eligible. I have a discussion with patients. I generally do not, as I try to follow the data for as it was unresectable. Is that the right answer? I don't know. And if you were to ask me, maybe in 6 months, have I changed my mind? There's a good chance I may have.
Yeah, the earlier days, our tumor board discussions would be very lively with the management of Pancoast tumor, and we would discuss this ad nauseum. Not the immunotherapy, of course. We talk about the chemoradiation, surgery, etc. And in the absence of nodal involvement after complete resection, these patients, I always thought, did better than our stage 3 patients with nodal involvement. And you're right, the Pacific studies did not include patients who underwent surgery. Also, the number of patients who were included with Pancoast syndrome, I think that number is likely to be lower. I don't recall, I don't think it was mentioned in the paper, and but it was not an exclusion criteria. At stage 3, they would have gotten in. But I suspect that given the lower prevalence among the stage 3 population, the data would be very limited. But it is one of those things, data-free zone, and I think we have to be open and have this discussion. And I agree with you. My approach would have been not to give it, but I could see a very ugly tumor, lots of residual disease after operation, a smoker. I may be persuaded to give durvalumab in those patients who have lots of residual disease after treatment, given how morbid this disease can be when it recurs, with all the local pain and discomfort, etc. Yeah. Any closing thoughts?
I have a question to the medical oncology colleagues. If you chose that route of durvalumab in this disease, would it be covered by insurance?
That's truly $1 million question, figuratively and literally. And it depends on the insurance company, the location, the persuasiveness, and who you're talking to on the other side.
Yeah.
Okay.
So it's a hit and miss. And I also don't see I don't see any trial that I'm aware of where this question is being asked in superior sulcus tumor specifically. And I suspect that such a study would be very hard to pull off.
One more point I just want to make. I know we're short on time. This patient probably, and this is another controversial area, but this patient probably warrants genetic sequencing of the tumor. I mean, it's an adenosquamous. No, we're not going to use that information now, but a high risk of recurrence where that information could be leveraged on down the line. Now, you could make the argument when they recur, then do the biopsy and do the next generation sequencing. But I think it's a good idea to get these results up front so you have it and ready if the patient recurs, and the high likelihood that the patient may recur.
Yeah, that's a good point, and I think but I think you definitely can do that, especially if you have adequate tissue. But I think it's important to keep in mind that targeted therapies have no role in these contexts when a curative, plain old-fashioned chemoradiation surgery, those things help and cure these patients. One thing I want to point out, my own view from the genomic side is that the adenosquamous, for large part, are adenocarcinomas. They have some transdifferentiation. But again, these cells are very plastic. We have seen adenocarcinoma become small cell. We have seen, so these tumors actually can transition very quickly. I treat adenosquamous more like adenocarcinoma. Any thoughts you have, Dr. Levy, on this?
Yeah, I default. I think that chemotherapy selection can be challenging sometimes for the advanced stage setting. Do you use a entirely specific histology-directed chemo with adeno, with pemetrexed, or do you default to something more non-specific like carboplatin and paclitaxel or nab-paclitaxel? I do tend to gear my treatment more towards the adeno side for these mixed histologies.
Yeah, very good. Excellent. Thank you very much. Thank you. Great discussion.